Thanks. Glad to be here for a very high-quality meeting. If I do that. So we're going to talk about mitral stenosis. I thought I'd start with a clinical slide of a chest X-ray, which is pretty classic for mitral stenosis, with the left heart border straight and the double density left atrium showing up there, and a big right heart and a small left heart. So the first intervention for mitral stenosis was in 1925, believe it or not, in Boston, where this fellow Cutler designed what he called a valvulotome, and he stuck it through the apex and cut the valve. And actually, his first patient, it was a success. This was a I think 11-year-old girl, and she went home thereafter. But then he tried it on a few more patients and ended up with severe mitral regurg and deaths. And so he was kind of, I think he was barred for a while, even though he got it started. And this was his paper, how it was written in 1925. Things got a little livelier in the late 40s and early 50s when Dwight Harkin in Boston and Russell Brock in London developed closed commissurotomy. First, it was just a finger puncture through the apex, and then later came the Tubbs dilator. I don't know if any of you have seen a Tubbs dilator, but at the end of the left side of the screen is a finger that went through the left atrial appendage, and then the right hand is through the apex. So they didn't want to get the cord. So in order to put this right at the center of the valve, the finger went through from the left atrium, and then they caught it finger to finger, and then split the valve. And that was a very successful operation. In fact, of course, this is a study from India with a large number of patients. This is closed commissurotomy off pump through the apex. And I'm going to put my glasses on here. And you can see the 10-year results were pretty good. Death without intervention is well up over 80 to 90%. So it was a good operation. And the symptoms, again, at 10 years, you can see at the pre-op, they're all class 3 and 4, and at 10 years, not too many 3s and 4s. So in 1984, Koki Inui in Japan developed this balloon valvuloplasty with a latex balloon. He was actually a cardiovascular surgeon. And I'm sure you've all seen pictures of this. This balloon inflates in 3 segments: the distal segment, and then one pulls it back into the valve, and then the proximal segment dilates in C, and then you finally dilate the middle part. So this was actually the first valve, the first balloon used in valvuloplasty, but in North America, the double balloon technique seemed to get a better start, mostly led by the Boston group. And the double balloon technique, I will skip that. The double balloon technique involved putting 2 balloons side by side, so one crossed the septum with one and crossed with the other, and then inflated both. Now this is cheating a little bit. This slide is the Bonhoeffer technique. But anyway, it shows 2 balloons. And the problem with this technique was that the balloons slipped. And they would either slip back and tear the left atrium or slip forward and tear the apex. So cardiac rupture was a problem. It was very hard to stabilize this. So, in fact, the Inui balloon really took over. In a comparison with the Inui balloon and the double balloon made a slightly bigger valve area at the end, but in terms of follow-up, there was no difference. So then our friend Bonhoeffer, who was mentioned this morning, he looked at the problems in Africa and the cost of the Inui balloon. So he came up with this double balloon technique using a multi-track. So it was 1 wire. So instead of crossing the septum with 2 wires, you crossed with 1. You placed a distal balloon with a short slider, and then the proximal balloon side by side. And so it made it a little easier and a lot cheaper. So actually, so one of his early papers, you can see my name in the middle there. So he came to St. Michael's and we did some cases together. He put my cases in his series, which was pretty good, I guess. But then when he left and I tried it, almost the first case I tried it, bam! I tore the apex and I never used it again. so that was the end of that. I think things. There was a debate about open commissurotomy. As the pump surgery came, then the surgeons really stopped doing closed commissurotomy and did open commissurotomy, and they liked it better because they could see the valve, they could free the cords, they could cut the way they want right down the commissures. And so there was some debate for a while, which is the best technique. And this trial from Saudi Arabia really kind of changed things for all of us when they compared balloon valvuloplasty in clear, speckled is open commissurotomy, and black is closed commissurotomy. So this was a randomized trial of the three groups, and you can see on the top right there that the mitral gradients at 6 months were best with the open with surgery and open commissurotomy, and a little worse with closed commissurotomy. And this stood up after 7 years. So in fact, balloon valvuloplasty pushed surgery out of the way back in 19. So again, a lot as in all our doings, selection is the issue. And so how do we select a patient? Before echo, the Paul Woods of the world, the cardiologist, would go to the bedside and listen for a loud S1 and a clear opening snap and a good rumble and no mitral regurgitation, and Paul Wood would go to Russell Brock and say, "This is for you." And if he didn't hear a good opening snap or a soft first heart sound, that was probably a valve that wasn't moving very much, and maybe better not try this. And in fact, this is still valuable today. I think anybody doing valvuloplasty needs to just remember this. But of course, when echo came along, we classified valves with the Wilkins score, which you've all heard about, and we looked at the mobility of the valve, the thickness of the valve, subvalvular and valvular calcification, and there was this scoring system developed to try to predict what would work and what wouldn't. And 8 was the magic number. If your echo Wilkins score was greater than 8, then you didn't do as well. So this slide shows your immediate result. You can see on the bottom, as the echo score gets higher, then the final valve area gets lower. So you don't get as good as result. And if you look on the bottom right there, if you look at long-term follow-up, again, if your echo score is less than 8, then your long-term outcome is better. In fact, the echo score, I kind of stopped using it a long time ago, and just looked at the valve and made a decision based on gestalt almost. And because you got different echo numbers from different labs, and it didn't make. The other point I should make now is your echo score does not come from TEE, it comes from transthoracic. So many people get that mixed up. It's a transthoracic thing. But anyway, I kind of stopped, and then this paper came out by the same group in Boston, and anybody who's doing valvuloplasty really should read this paper, because I think what it changed my thinking about it. Something we didn't look at before, it was very important, was this asymmetry of the commissural involvement. And if you had symmetry, you were much less likely to get mitral regurgitation. If you get a valve with that's asymmetrical, like that bottom left picture, then you're going to dilate the other side more than the commissure and have trouble. So mitral regurgitation is much more common in that. So I used that. This paper was very important. And in fact, when they looked at outcome, the predictors of outcome were smaller valve, which of course makes sense. But they also looked at a leaflet movement. That is, how much is the anterior leaflet moving? If it's moving more than 12 millimeters, and that's mobility. So mobility is important, and this ratio of commissural fusion is very important. And I must say that's what I'm using today. And this is what you want at the end of the day. Pre is a valve that has symmetrical commissural fusion. At the end, you can see both. At the bottom, you can see both commissures have split there. So this is some preliminary work. This is a lot of retrospect work, and I'm not. We're working on it, but we've since about 1990. I forget now. 1998. That's right. We've done about 240 cases. We may have missed a few along the way, and of course, most are female. That's the nature of mitral stenosis. And these are the procedures that we've done for a year. I think we may have missed a few early on, but we're still working on this. It's interesting where our patients have come, where 71% have come from Asia, and mostly India. And that kind of fits with the prevalence of rheumatic heart disease around the world. You can see that India far outweighs the others. But again, being in Toronto or the Toronto metropolitan area, this is why we see mitral stenosis, and folks in other parts of the province may not. And the age, again, you can see our population is somewhere between 35 and 50, even 60. In India, of course, it would be a lot lower. They have this juvenile rheumatic disease that's where these young people get bad disease. Ours is a little slower. And in our follow-up, we had 22 deaths in follow-up. And those who are living, 77% had no further intervention. 23% either had repeat valvuloplasty or surgery. We've done quite a few second valvuloplasties, and there are two where we've done 3 over time. And again, I think I'll just skip that. This is the incidence of tricuspid regurgitation. I just want to make the point that you can see very little at the very severe tricuspid regurgitation. There's 6 patients. We've tended to stay away from that, mostly because when you see a patient with mitral stenosis and severe tricuspid regurgitation, first of all, it's a signal that you're not going to get a good result. Like a lot of things, tricuspid regurgitation is a sign of disease further along the way. And usually in these patients, if they have bad tricuspid regurgitation, why don't you send them to surgery, get the tricuspid regurg fixed as well as the mitral. And what happened to the mitral regurgitation? Well, there was no change in most. In 13 patients, we went up 2 grades. And you'll see that in 5 patients, in our experience, had to go to emergencies or surgery while in the hospital, and 2 right from the cath lab. One of them was my Bonhoeffer case. We had 1 ASD that we needed to close with a closure device later on. She came back with severe right heart failure. The valvuloplasty worked, but the ASD was too big. A couple of tamponades along the way. I think I have time for a case. I'm going to show you a case here. Just a second. There's 2 cases, but anyway, we'll do this one. This is a 77-year-old woman who had previous open commissural. How much time do we have? A couple of minutes? Fine. Okay. A 78-year-old woman with an open mitral commissurotomy. She was diabetic on oral agents, hypertensive, hypothyroid. She was presented with this cough. It was going on and on and on. Orthopnea, ankle swelling, and she kept going back and forth to emergency. So she was transferred to St. Mike's for consideration of balloon valvuloplasty or mitral valve replacement. So she's 5 foot tall, 64 kilos, blood pressure 160/70, satting well. Venous pressure was sky high with prominent RV, normal S1, and a short mid-diastolic rumble, and no opening snap. And those were her medications, lots of diuretic, but venous pressure is still high. That's her ECG, not a lot to say, atrial fibrillation. That's her chest x-ray. You can see some plethora in the lung fields. I think we can probably see a big left atrium there too, and a splayed carina. Not quite as nice as the last x-ray, but it's there. And a big right heart. So this is her mitral valve, and you can see the mobility here is not great. You can see the thickening. We can't assess the subvalvular too well here. Again, there's some subvalvular involvement. The anterior leaflet is somewhat mobile, but this isn't a great valve. Her mitral gradient was 6 by echo, and her mitral valve area by pressure half time 1.5. This was what have I got here? I think this is her TR, right? So her RVSP is somewhere 44 plus right atrium. So what would you recommend in this question? Would you recommend mitral valve replacement, balloon valvuloplasty, or medical therapy? So we don't have the answering system, but you might just ask yourself that question and write it down. Well, I might ask, who would do valvuloplasty? Okay.
What are her symptoms?
She's recurrent heart failure to emerge, constant cough, and back and forth to emerge left and right. So, well, we did do the next test. We did do a catheterization. Her coronaries are okay. This is her LV angio, and she's got some calcium in that valve. You can see it just before we start. Not a lot of mitral regurg, good left ventricle. That's her aortic pressure. Looks 150, 160 over 60. And her mean RA is 14. Her PA is 80 over 24 with a mean of 44. And this is her wedge pressure with V waves of 53 and a mean of 33. And this is her LV and wedge pressure together. Okay. So the mean gradient with LV and wedge is 14.7 or 15. Cardiac output 3, so the valve area comes out to 0.77. So who would replace the valve? Balloon valvuloplasty. Anybody do balloon? Couple. 1, 2, 3. I'm trying to remember. I'm sorry. I didn't write that down. I think from the RA, I think it wasn't. We can go back to that RA trace because I don't remember what the echo showed. But it's not it's high. It's RA pressure. I think she must have had some TR. Let's say moderate with RV failure. I think.
I mean, that looks like pretty mild TR.
Yeah.
Just in terms of the amplitude of the waves
Yeah.
and stuff. I mean, it's not.
I'm not sure how big our atrium is and stuff, so they all have some. So I don't think TR was a big deal in this.
Do you think on echo that the valve? I was kind of fleeting your talk while you were presenting, but do you think on echo that the valve was severely narrowed or no? The mean gradient was 6.
Yeah,
So
but by echo we didn't. By echo we did not. You know,
so
the 6 is
there's other causes for a wedge LV gradient.
right. So okay, so would you do another test? So we did do another test, and this was the transeptal, and that's her gradient with the transeptal, 8. So what does she got? What does she have? What does she got? Okay. Pardon? No. No. That's what she's got. That's what she's got. And you'll see, yeah. Yeah, you'll see that. Yeah.
I mean, definitely with a big V wave, no MR, you have to think of the stiff
Yeah.
count.
Yeah.
But could her loading conditions have been different? And I don't know if the heart rate was the exact same. Some of these patients, as soon as the heart rate tracks out, all of a sudden the gradients increase significantly, much higher than someone who doesn't have such a stiff left atrium. Did you try anything like Dobutamine or anything like that?
Actually, I did the transuptal and went home. That's what I did. Because I think that explains her pulmonary hypertension, which has been pretty constant. Yeah. Yeah. And we've had the valvuloplasty patients where you do it, and you end up with this. You end up after the valvuloplasty, you get this big left atrial, and they got two problems.
So during your technique of valvuloplasty, you do it under conscious sedation?
Oh yeah, oh yeah.
And then that's the other question is, do you ever pace during that? I know the ventricular pace is not the same as atrial, but just the question that was just answered.
I mean, the only time I've done it is when I need to prove to somebody that the mitral stenosis isn't, patient has, it's like the stress test. So the patient has a lot of symptoms and a gradient of 3 or 4, isoprel as opposed to pacing. Yeah, Sammy.
I guess the other clue is the lack of in-depth heart treatment. The gradient is mostly early.
Yeah. In fact, one of the questions that this is what I asked the residents: what's the best measure of mitral gradient? Just to make the point that number C is not very good. That echo was much better than.